Hi everyone. Today we are thrilled to have Dr. Jes Olesen as our guest for Editor's Choice article journal of Cephalalgia and a very famous headache specialist and did so much for headache medicine. We are thrilled to have you, Dr. Olsen. Could you please tell us a little bit about yourself, where you practicing now, and what brought you to this amazing research? Please.
Well, thank you. I'm a professor at the University of Copenhagen in Denmark, and I have been a chairman of the Department of Neurology. And in that function, I have partly, obviously, started and driven for many, many years very intensive research into the different kinds of headache, but also organized a very comprehensive center for the treatment of headache disorders called the Danish Headache Center, where many of my pupils now are quite famous, like Professor Mesut Ashina, Professor Rigmor Jensen, Professor Lars Benson, and so on.
Yes, this is very beautiful center and so much research coming out of your center. So thank you so much for doing this fantastic work. Your article talks about methodology, which is really burning hot topic in every research in headache medicine. Could you please tell us a little bit about how you came to write this article, what was done, and what were the conclusions?
Yes, well, it all started in the late 1970s, so it's about 50 years ago, when we got a grant from the Danish state to do a prophylactic study in migraine. A very stupid study in a way, because it was like homeopathic medicine that the politicians wanted us to study. But the good thing was it gave us a completely free hand, and we then studied everything we could about drug trials. We found that there were no rules and no standards for drug trials of migraine patients. And we studied then principles in other diseases too, and actually came up with a methodological paper in the first issue of Cephalalgia in 1981, called The Methodology of Drug Trials of Prophylactic Migraine Treatments. In those days, there was only prophylactic treatments. And we outlined there the main principles that should apply to good studies of drugs for the prophylaxis of migraine. And from there, we went on, and I must say it's with my highly esteemed colleague, Tfelt-Hansen, who still today, several years after his retirement, is kind of a watchdog who is really screening the literature, and he's actually focusing on whenever people do mistakes and don't use proper conduct in drug trials, he will be there with a letter to the editor and so on and so forth. So it's been a wonderful collaboration with him. We later made a paper on the methodology of drug trials of acute treatment of migraine attacks. And then one of the problems was how to make sure that a drug trial would include the right patients. But then in the meantime, fortunately, I had initiated and chaired the International Headache Classification, the International Classification of Headache Disorders. First edition came out in 1988. And then we knew, obviously, also how to make the right diagnosis. And a couple of years later, I became president of the International Headache Society. And I then appointed my my friend and combat colleague Tfelt-Hansen to be chairman of a committee under the International Headache Society to elaborate on the methodology of drug trials, because that would make it official and that would assure that the criteria would be used all over the world, just like was the case for the International Headache Classification. And Per and his colleagues did a fantastic work and came out then with the first guideline for drug trials in migraine, which was officially a document of the International Headache Society. And after that came second, third edition, and then it went on to other people. And there's been a number of these official guidelines for drug trials.
That's amazing. And we all now using international headache classification, which you play such a huge part. We are very grateful. And methodology, very helpful for us to all move forward. In your article, you discussing very interesting migraine with aura, migraine without aura, pediatric and adult, primary endpoints such as what happens with pain levels in couple hours, what about most bothersome symptom. What do you think we should be looking at now and in the future as primary endpoints for trials for medications for migraine, acute and preventive?
Yeah, well, in the acute trial, I still believe that the main outcome parameter is the pain, because there is a lot of evidence indicating that the other symptoms, such as nausea, vomiting, hypersensitivity to sound and light, and so they are dependent on the pain. So you treat the pain, the other symptoms go down in parallel, or even more actually than the pain. So I'm not in favor of this most bothersome symptom, but it's something that the FDA has decided. I think it's superfluous, but it can, of course, be used, and it doesn't do much damage because it's always going to show exactly the same as the outcome for pain. So in prophylactic trials, the big discussion has been whether one should have migraine days or one should have migraine attacks. I prefer the migraine days because you have these patients who have attacks lasting 3 days, and if they have 2 attacks a month, it's 6 days a month is an awful lot, and they should definitely have prophylactic treatment. But if you then say 2 attacks a month, it doesn't sound like very much. So, and this is true because if it's a short-lasting attacks, usually lasting 12 hours, and you have 2 attacks per month, and if they respond to acute treatment, then there's no reason to use prophylaxis.
Beautiful way of thinking. What do you see in our future in migraine and headache medicine? Nearest future, maybe further future research?
Well, first of all, what I see is a golden future because we've had the major breakthroughs with the human provocation model, and we have shown, we showed many years ago the importance of calcitonin gene-related peptide. Now we have the drugs revolutionizing the treatment, but we also showed that PECAP can do it, and my colleague Masoud Ashina has shown several other naturally occurring substances that can induce migraine attacks. And when a substance can induce a migraine attack, it seems that there's a good chance that an antagonist can be used to treat the attacks. We still don't know for sure, but it seems to be the case also for the PACAP, because there is a paper showing effect of a PACAP antibody in the prophylaxis of migraine. So I think we're going to look into a future with many drugs that work for migraine, and they are different, and eventually this will lead to personalized medicine where you have to match each single patient to the drug that's best for that patient.
That's excellent. So, individualized treatments for every patient. We
Yeah.
really appreciate this interview and all your research, so helpful for headache medicine community. We love your work in the journals of Cephalalgia and International Headache Society. Really appreciate editor's choice. Congratulations from all our team of the journal, and we hope to see you again really soon. Thank you.
Thank you very much.